Welcome to the 2022 CGA-IGC podcast series, brought to you by the Education Committee. This season, we'll be hosting a virtual journal club. Each episode will highlight a recently published article that is important for the field of GI cancer genetics and feature an interview with one of the article's authors. Keep listening to find out more about the episode's host, guest, and featured article. Hello, everyone. Welcome back to the CGA podcast. I am Dr. Thomas Slavin, TJ. Privileged to be here with some great guests. We have Bryson Katona. He is a MD PhD, director of the GI Cancer Genetics Program and assistant professor in the Division of Gastroenterology at the Department of Medicine at the University of Pennsylvania. Also, are privileged to be joined by Jessica Long. She is a genetic counselor in the Division of Hematology and Oncology in the Department of Medicine at the University of Pennsylvania. Thank you both for coming on today to talk about your recent paper. We are going to be talking about a paper published in November of 2021 on cancer prevention research, the journal, and it's termed EUS-based pancreatic cancer surveillance in BRCA1, BRCA2, PALB2, ATM carriers without a family history of pancreatic cancer. So, hot topic on pancreatic cancer screening. Thank you both for coming on today.
It's a pleasure to be here. Thank you for having us.
Thanks so much, TJ. And I'd just like to thank the CGA Education Committee for the opportunity to come on and talk about this paper.
So let's just get into it. What really led to the concept of this article?
No, this article was actually really based off of some of the initial data from a pancreatic cancer surveillance study that we've been conducting here at Penn since about 2015 or so. For our particular study, we were enrolling BRCA1 and 2 carriers, ATM and PALB2 carriers, but specifically those who do not have a family history of pancreatic cancer. And we were enrolling them into this study to offer them pancreatic cancer surveillance. The reason that we actually started this study was that there's really a lack of data for pancreatic cancer surveillance outcomes amongst these carriers who don't have a family history of pancreatic cancer. And for years, pancreatic cancer surveillance for mutation carriers have really always required having a family history of PDAC. We kind of anecdotally noticed over the years before starting the study that actually many of these carriers seem to be very interested in pancreatic cancer surveillance. And, I think that's very reasonable, given that the majority of pancreatic cancers who develop in BRCA1 and 2, ATM and PALB2 carriers actually occur in individuals who don't have a family history of PDAC. So, these individuals are understandably very, very concerned.
Yeah, and we have some guidelines now on looking at people with a family history, someone in the family, close relative with pancreatic cancer. It's interesting that you went down this path. And what were some of the challenges of really relying on the family history in your minds when it comes to pancreatic cancer surveillance recommendations?
We know that reported family history may be limited or unknown for various reasons, such as adoption, estrangement, small family size, and deaths at young ages due to other causes, including other cancers. Additionally, when obtaining family history in clinic, I often hear patients describe how their relatives may not openly discuss cancer history, either due to privacy, fear of speaking about cancer, and sometimes cultural factors. So there can also be a lack of certainty about the primary cancer site. For example, stomach cancer versus another abdominal cancer like pancreatic. And it's been well documented in the literature that the reported family history from patients and as recorded in the medical chart may be inconsistent or inaccurate, and also fluid, meaning that it changes with time. So while family history of cancer does remain a very useful and important tool for cancer risk assessment, it's also important to be aware of these limitations as well.
Mm-hmm. And so what were the major goals and findings of the research?
The major goal of this research and of this paper was to look at the feasibility and get at least some early outcomes of pancreatic cancer surveillance in these BRCA1 and 2, ATM and PALB2 carriers without a family history. And as far as findings from the paper, one, we showed that it's feasible to perform pancreatic surveillance in this cohort, and there's actually fairly significant interest amongst these patients in pursuing pancreatic cancer surveillance, even in the absence of a family history. Our particular cohort, it was primarily a female cohort, and primarily it was BRCA2 carriers. And our median age for first EUS was around age 62 or so. But what we found was actually that the rate of findings on EUS in this cohort, both inside the pancreas as well as findings outside of the pancreas as well, was actually pretty high and was very similar to some of the higher risk surveillance cohorts. And so just for an example, pancreatic cyst was the most common finding within the pancreas. We found a cyst in about 27% of patients.
Wow.
And 41% of patients actually had findings outside of the pancreas that were picked up on the upper endoscopy. And many of these findings were precancerous findings, such as Barrett's esophagus or gastric intestinal metaplasia, all things that we feel are important findings for these individuals. And we actually identified 2 pancreatic cancers during the surveillance in this group. One was caught in an early stage, one at a later stage. But this finding of kind of this rate of pancreatic cancer amongst this group is typically in a similar range to what would be expected in a higher risk screening cohort, where it's thought that typically need to screen about 100 individuals to find a high risk lesion. For the people listening, it may be interesting to hear a little bit more about these 2 pancreatic cancers that were found. But interestingly, the first one was actually found in a BRCA2 carrier who had her initial EUS at age 58. And on that very initial EUS, totally asymptomatic, she was found to have a fairly large 14 millimeter cyst that was aspirated and actually came back with high-grade dysplasia. And she subsequently had a distal pancreatectomy where they found a 3 millimeter focus of pancreatic cancer. And so this is a really good catch in our mind. The other patient was another woman with BRCA2 mutation. She'd actually begun a yearly surveillance between age 72 to 74. But then for personal reasons, decided not to undergo surveillance at age 75. And unfortunately, when she came back at age 76, she had a 3 centimeter pancreatic cancer with, unfortunately, some metastatic disease that was found.
Yeah, that's amazing. What do you think the major impact of this work will be?
So I think it serves as an illustration that pancreatic cancer surveillance certainly can be performed in all BRCA1 and 2 ATM and PALB2 carriers, and that it can be performed safely. We actually found in our cohort that there were no significant complications for any of our patients. And importantly, there were actually no unnecessary surgeries performed, which in terms of pancreatic cancer surveillance, one of the biggest risks is always the fear of sending somebody for a surgery for a potential high-risk lesion that ends up not being high risk. And so I think that since there were no unnecessary surgeries, that is a plus on our side. We hope that the results from this article will lead to really increasing debate about whether or not BRCA1 and 2 ATM and PALB2 carriers without a family history, whether or not these individuals should be more routinely considered for pancreatic cancer surveillance, or at least merit a discussion about pancreatic cancer surveillance with their providers.
In clinic, how many of these patients do you think with germline mutations in BRCA2, ATM, PALB2, how many do you think realize there's a pancreatic cancer risk, or is that something talked about a lot?
We find it's not uncommon for patients to be surprised when hearing about the pancreatic cancer risk, even among those who've had a known genetic diagnosis for a number of years. Admittedly, the pancreatic cancer risk may not be the first risk addressed by most clinicians, given the significantly increased risks of breast and ovarian cancers with some of these genes. So also among many patients and providers, there's generally less awareness about the cancer risk associated with PALB2 and ATM, although this has been steadily improving in recent years. I would say for the genetic counselors, from our perspective, it's often a careful balance when we're discussing cancer risks in terms of informing patients while also not excessively increasing cancer-related worry and fear. I often try to help patients understand that although the pancreatic cancer risk is increased, it's still a low percentage risk, although it's very significant for those who are affected. And unfortunately, at this time, we can't accurately predict who among mutation carriers will or will not be in the minority to ultimately develop pancreatic cancer.
And if I'm a germline mutation carrier now with one of these, what are some of the challenges and barriers or factors that might influence my decision to start pancreatic cancer surveillance?
I think one of the biggest issues without a family history at this time is actually getting insurance coverage for the surveillance. At least from our experience here, we know that surveillance in BRCA1 and 2 ATM and PALB2 carriers without a family history is not always covered by insurance, and oftentimes requires a decent amount of back and forth between our clinical team and the insurance company to try to get these scans, either EUS or MRI, covered. Anecdotally, in our experience, I think we've had less issues with endoscopic ultrasound compared to ordering MRI. And I think that's probably because for MRI, there's very stringent approval processes that are kind of in place for all individuals who have an MRI that is ordered. But I think that insurance coverage becomes far more easy down the road if there is a finding on an initial exam. And so if somebody comes in, we do get one EUS covered and they're found to have a pancreatic cyst. Usually the fact that that cyst is there is going to allow all of their future exams to get covered without any difficulty. But I do think that if guidelines expand to include BRCA1, 2, ATM, and PALB2 carriers for surveillance regardless of family history, that will certainly help with insurance coverage in the future. Yeah. Jess, what are your thoughts on that?
Yeah, I think it's also important to consider that we encourage our patients to have very dedicated discussions with experienced providers about the potential risks and limitations along with the benefits when making decisions about surveillance. And as such, it's also possible that clinicians may steer a patient towards or away from surveillance depending on the clinical judgment of the patient's own unique situation. So, even with these expanding guidelines, really taking into account a clinician's own assessment of the existing data, and there may be provider clinical practice-based differences that ultimately influence which patients do proceed with the pancreatic cancer surveillance too.
I do think that that's such an important point because individuals who are getting into a pancreatic cancer surveillance program, it's just so important for them to understand and know what they're getting into. And that really requires a discussion about the pros and the cons of surveillance. I think the uncertainties of surveillance should be highlighted with individuals. And then also, I think it's important for providers when they're pitching surveillance to make sure they're pitching it to appropriate people, especially with regard to age and overall health and other comorbidities. If early pancreatic cancer or early other type of high-risk pancreatic lesion is identified on surveillance, you want to make sure that that patient's actually an appropriate surgical candidate. So if you had a patient who had an early pancreatic cancer found but couldn't undergo a surgery to remove it, then you would ask, is surveillance really appropriate for that patient in the first place?
Which individuals are you finding are most motivated to pursue this type of screening?
Based on our study demographics, not surprisingly, those with a known family history of pancreatic cancer pursue surveillance most often. 64 of 194, or about a third, pursued surveillance with no family history known for pancreatic cancer. And of this cohort, the majority were female, about 72%, and 2/3 had a prior personal history of cancer other than pancreatic cancer. I do think it's important to note that for our study cohort, our patients are generally highly motivated, having sought out care at an academic medical center, often seeking cutting-edge procedures and research. And some specifically seek out or are directed to our center by referring providers for discussions about pancreatic cancer surveillance in either Penn Medicine's gastrointestinal cancer genetics program, and others have been motivated to pursue care affiliated with the Vassar Center for BRCA. As well, we follow a number of women with BRCA mutations who have already pursued risk-reducing surgeries, such as prophylactic bilateral mastectomy or risk-reducing salpingo-oophorectomy. So often they are now asking what else can they do to manage their HBOC-related cancer risk, because after these significant risk-reducing surgeries, one of the highest remaining lifetime risks is the pancreatic cancer risk. Anecdotally, we find that those who are less likely to pursue may have a current cancer diagnosis, who prefer less medical intervention, or they're more concerned about the risks of procedures, or are just less concerned about cancer risk in general.
As we brought up in the beginning of the podcast, this is a hot topic. What are some of the other exciting initiatives that are going on right now in the field?
I think that one big happening in the field that definitely deserves a bit of discussion around this topic, and this happened several months after our paper came out, it was actually just a couple months ago, were the new ASGE guidelines for pancreatic cancer surveillance. And so these guidelines actually came out in support of pancreatic cancer surveillance in BRCA1 and 2 carriers and PALB2 carriers starting at age 50, really regardless of family history. And I'm sure you've probably seen them, TJ, but they really maintained that a family history was still needed for ATM carriers and Lynch syndrome carriers, but for BRCA1 and 2 and PALB2 carriers, it was not a requirement. And so this is a major departure from from prior guidelines and really is the first guideline to really ever promote pancreatic cancer surveillance for all of these carriers. Now, I will say that these recommendations were conditional and based on very low quality of evidence, as was stated in the guideline, but it's still potentially a paradigm shift in the surveillance guidelines. And we'll have to see if other guidelines like the NCCN followed the lead of the ASGE. But even if they don't, maybe at least having some guideline out there will help individuals get coverage for these surveillance procedures. I think one other initiative is the ongoing pancreatic cancer surveillance studies that are prospectively following patients undergoing surveillance and collecting data on their outcomes. I always tell patients who are going to undergo surveillance, I think that everybody that undergoes surveillance really should do so while enrolled in a pancreatic cancer surveillance study, because that's really the only way that we're going to be able to collect data and move the field forward. Now, there's a couple of studies that are out there. One is the NCI-funded CAPS-5 study. This study has been ongoing for 6 years, and there's 8 participating centers. We participate here at Penn. Outcomes data from this study will be presented at DDW this year, and the data is incredibly powerful and I think really provides a lot of support towards the benefit of pancreatic cancer surveillance. However, at this time, though, CAPS-5 really only enrolls mutation carriers with a family history. There's also the PROCEED study, and Jess, maybe you want to talk a little bit about that one, but the PROCEED study actually enrolls patients without a family history who are undergoing surveillance.
Sure. The Pancreatic Cancer Early Detection Consortium, or PROCEED, it's an international multi-institutional collaborative group with over 35 centers currently participating right now. And this is a really exciting endeavor to accumulate more longitudinal data on pancreatic cancer surveillance for high-risk individuals, as well as to facilitate efforts to develop better tools for risk stratification, such as including options for better prediction of which individuals would most benefit from pancreatic cancer surveillance. And as Bryson mentioned, this consortium does have broader eligibility criteria than the CAPS-5 study, as it does allow enrollment of BRCA and PALB2 carriers without a family history of pancreatic cancer.
Yeah, a lot of good work going on. And what are you both working on now in the field?
So one of our newly initiated studies is evaluating the psychosocial impact of pancreatic cancer surveillance. We have a fantastic Penn genetic counseling graduate student by the name of Isabel Inez Bruzual, who's leading this effort. And in this study, we're trying to assess potential non-cancer related benefits of pancreatic cancer surveillance in high-risk individuals, such as potentially stress reduction and reassurance to patients after a normal surveillance result.
Yeah, I'm really curious to see how that turns out. I do think that surveillance does have a lot of other benefits for these high-risk patients. One other thing that we're also continuing to work on and think about is trying to address racial disparities in access to pancreatic cancer surveillance. Over 90% of the patients who participated in our study were white, which really highlights some of the clear disparities in who is enrolling in these pancreatic cancer surveillance studies, and really suggesting that there may be potential barriers to getting people into these surveillance studies. And this is not just an issue with our study. This is one that has been pervasive across all of the pancreatic cancer early detection studies. And I think it's clear that we really need to do a better job of getting more diverse populations enrolled into these incredibly important programs. And then some of the other areas where we have ongoing work is looking at developing new pancreatic cancer biomarkers to be used for early detection. And I think that these large consortiums and the biosamples that they collect are going to be so important for really moving some of these new candidate biomarkers forward. And then we're also interested in trying to use artificial intelligence to better detect early pancreatic cancers on imaging. So maybe on an MRI, you may not see a mass in the pancreas, but there may be some subtle signal changes that could be picked up by artificial intelligence that may convey that the particular individual has a higher risk in the next 6 months or 12 months of developing a full-blown pancreatic cancer. So I think there's just a lot of really exciting momentum and research in this field, and I'm excited to see how much progress we can make over the next couple of years.
Sounds like you both have your work cut out for you. So, no, this is great. So we covered a lot of ground. For those who haven't seen the publication, please go pull it. Cancer Prevention Research in November 2021. And it's EUS-based pancreatic cancer surveillance in BRCA1, BRCA2, PALB2, ATM carriers without a family history of pancreatic cancer. Great discussion here. Field is really at its infancy of where we're probably headed with it. So thank you, Bryson. Thank you, Jessica, and have a great rest of your day.
Thanks so much, TJ. Really appreciate it.
Thanks so much.